But it doesn't just work. It isn't just worth doing in circumstances where health systems are growing and you want to make sure resources are being used effectively. It's a means of deciding how to optimize the money that you've got available. If you're getting more money coming into the system and you want to do more, that's fine. You can make good judgments about new products. If you're in a situation where the NHS in the UK certainly is now, most health systems are, things are tightening down because of the global economic position, it's almost more important that the judgments you make about what to acquire for the healthcare system are based on a good quality understanding of the incremental benefit for patients of new technologies that come in. And it's that assessment, that evaluation of the incremental benefit for patients that's at the heart of this process. It's not some sort of measure applied by accountants to stop healthcare systems spending money. It's a means of understanding the incremental therapeutic benefit. And you can stop there. You can decide that's enough. You can distribute that information and let whoever it is that makes judgments about how to acquire or what to acquire in any part of a healthcare system make their own minds up about whether or not that acquisition is worth it in terms of the patients that they're responsible for and whether it represents value for money. Or you can do what NICE does, which is to go one step further for the whole of the healthcare system and make a judgment about whether a new technology both brings sufficient additional therapeutic benefit for patients, and then make that sometimes very controversial judgment about whether that additional benefit is worth what the health system is being asked to pay. That goes to one of the points that Thomas was talking about there. That's the economic evaluation, the value for money judgment. Now we can spend hours, and economists do, they love it, arguing the finer points of QALYs and other forms of economic evaluation. But in some ways that misses the point. All these systems, all these processes are imperfect in some way. They're all evolving, so they're all getting a little bit better. But they don't themselves give you the answer to the question, going back to the first point I made. They take you to a point where you're far better informed about the decision that you need to make about what to do in the interests of the patients that you're responsible for than you would be if you haven't gone through the process of objectively assessing a new product against what the health system currently uses. You need to make a decision that's based on the issues, the circumstances, the parameters that are important to the community of patients that you're serving as a decision maker in the healthcare system. And those decisions can be different in different countries. One country can decide that something isn't worth it based on their judgment about what their patients need, about what they can afford. Another country can make quite a different decision. And they're both perfectly legitimate. And they can be both, and indeed in many cases in Europe are, based on the same clinical evidence and a similar economic evaluation. You just apply a different judgment at the end about what all that analysis actually means for your particular health system, and whether or not what you know results in a conclusion which is consistent with what you're expected to provide for the health system or not. So the critical thing is do it well, go through the process of getting all the evidence together, involving those who are going to be impacted by the decision, the manufacturers, the people who represent patients. There are ways of doing this that allow you to do this efficiently. Do it transparently so people can follow the methods and processes, and build in some contestability. So there's a means of challenging the decision that might be made, or the recommendation or the conclusion that's being reached before it gets anywhere close to being published. Decide how you want to use it in the healthcare system. Don't feel that you have to adopt an approach in one jurisdiction, that that's the only way that you can use it effectively. Work out and share your conclusion on how this kind of analysis can benefit the healthcare system. But in the UK, it has worked. It hasn't affected, I don't think, although the UK is a small example, and I appreciate the point that Thomas made about the importance of the US system and the revenues that are generated in this country for R&D right across the healthcare industries. But this is a graph that shows gross value added in the life sciences industry in the UK over more or less the same period that NICE has been operating. 1997, we came in 1999 to 2007. Now you can argue, well, it might have been different if NICE wasn't around, but we have no control to demonstrate that one way or the other. But the graph's moved in the right direction as far as the life sciences industry is concerned and the UK economy is concerned in terms of the contribution of life sciences to the UK's economy. It doesn't stop investment either. This is for pharmaceuticals, not for medtech products, but it's foreign direct investment for new pharmaceuticals, new pharmaceutical projects in the United Kingdom. And it compares the Netherlands, France, Germany and the United Kingdom. And you can see there the United Kingdom is consistently a better performer than those other countries. They, of course, have different approaches to the funding and decision-making in their healthcare systems, but generally speaking, both France and Germany spend much more than the UK and are broadly, because they have a sort of co-payment mechanism, are able to move more quickly in terms of making decisions about and are more generous in terms of introducing new healthcare technologies into their health systems in the United Kingdom. But it shows the UK consistently ahead, and although there are ups and downs, again, through the period that NICE has been operating, holding up broadly. So we're not stopping, we're not reversing an important trend, we're not having an adverse effect on the view of the United Kingdom as a place to come and do business, at least for the pharmaceutical industry. And just as a final slide, here's an example of where it works for both the healthcare system and for a company. This is not a completely new product, but a product that's only been introduced very slowly into the UK healthcare system by Deltex. It's actually been evaluated through the newest of our technology evaluation programs. And interestingly, not through a program that uses quality-adjusted life years as a means of assessing value. This uses a straight cost consequences approach. This is an assessment of the business case on the part of the UK health system for adopting a new technology. It's looked at what we've got, it's looked at what's new, at its costs, but significantly at whether or not the value proposition from the company, which is if you introduce this new technology, you can drive cost savings into the system, really stacks up. So we've now got the ability to look at products where the value proposition is, this is more expensive, but it's going to drive improved outcomes for patients, so you'll want to do it because it's in the interest of your patients. That's fine. But we need a cost-utility analysis to look at that, which is why we use QALYs. But equally, we can apply a different approach. We can be flexible. So where the value proposition is, you need this because this is going to drive efficiencies over a short time period into your health system, we can do it in a different way, a different kind of economic analysis, and come up with an answer in this case, which has worked both for the company and I hope, it's a draft decision at the moment, will work in the interests of the NHS as well. So thanks very much for the opportunity of coming and talking to you today.